Good morning, everybody. Today I will be presenting a paper titled Addition of Metformin to Concurrent Chemoradiation in the patients with locally advanced non-small cell lung cancers. The results of a phase 2 randomized trial NRG LU001. This was published in JAMA Oncology by Skinner et al. So, chemoradiotherapy is a standard of care for stage 3A and stage 3 lung cancer. Recently, a Pacific trial has been published, which says that maintenance durvalumab can be a new standard of care. Coming to the metformin, which was an investigating agent here, it has an anti-neoplastic effects. It has a good safety profile and it's very low cost. 001 trial was started prior to the results of Pacific trial. The aim of our study was to check whether addition of a metformin improves the outcome in non-diabetic unresectable stage 3 non-small cell lung cancer with chemoradiation. It was an open label randomized phase 2 trial, was carried out between August 2014 to December 2016. They included all the patients with stage 3A and stage 3 non-small cell lung cancer, both adenocarcinoma and squamous carcinomas. All the patients were non-diabetic and they were planned for definitive CTI. Treatment arm consisted of radical radiotherapy to the gross disease and the involved mediastinal nodes to the dose of 60 grade 30 fraction over a period of 6 weeks, either with a 3D CRT or an IMRT. A chemotherapy schedule consisted of a weekly paclitaxel and carboplatin concurrent with radiotherapy, followed by 2 cycles of 3 weekly paclitaxel and carboplatin as a adjuvant chemotherapy. Two arm consisted of with or without metformin during the concurrent and adjuvant chemotherapy phase. A dose of metformin was planned for a 2000 milligram per day in 3 divided doses of 500 milligram, 1000 milligram, and 500 milligram 3 times a day. The primary endpoint of the study was progression-free survival, and the secondary endpoint consisted of overall survival, local regional control, and the toxicity. Coming to the results, they had identified 170 patients, out of which 84 were assigned to metformin and 86 were assigned to 84 were assigned to no metformin and 86 were assigned to metformin. Out of the no metformin arm, 3 were excluded. So final analysis included 81 patients to the no metformin arm and 86 patients to the metformin. Coming to the demographic characteristics, they were balanced between the two arms. The median age of population was 64 years. The adenocarcinoma and squamous carcinoma were in equal proportions. 2/3 of the patient consisted of stage 3A disease. Coming to the compliance, planned radiotherapy doses were delivered in around more than 90% of patients. The central review of radiotherapy plans shows that the 97% of the plans were concluded and the planning was done as per the protocol. Coming to the chemotherapy compliance, around 80% of the patients in both the arm completed the concurrent and the consolidation phase of the chemotherapy. Metformin compliance, around 63% of the patients completed the planned course of metformin for a concurrent and the consolidation. The most common result for discontinuation of the metformin was the side effect. Coming to the survivor outcome, the median follow-up of the cohort was 27 months. There was no difference in the survival in terms of progression-free survival, overall survival, local regional recurrence, or a distant metastasis between the two arms at 1 year and at 2 years. In the factors affecting the outcome, the higher stage had a worst PFS, like 3B had a significantly inferior PFS as compared to the 3A stage. These are the Kaplan-Meier curves for the progression-free survival, overall survival, local regional recurrence, and the distant metastasis, again showing that there was no difference between the two arms. Coming to the toxicities, both the arms had an equal toxicity except for diarrhea, which were higher in the metformin. 17% reported more than grade 2 diarrhea. as compared to 10% in the no metformin. Coming to the limitations of the study, metformin without modification, dose modification was given only in the 39% of the patients. Compliance and the tolerance to the metformin may be the additional variable affecting the results. Hence, there was no demonstrable benefits. Also, this study was not a placebo-controlled trial, primarily owing to the cost constraints. So they had planned as the open-label trial. Coming to the conclusions, addition of metformin did not improve the survival outcomes for patients with local regionally advanced NSCLC with chemoradiation. Survival outcomes were better as compared to the data from the previous randomized trial, probably due to they included non-diabetic patients only. However, they are postulating that recent trials suggest that addition of metformin to TKI immunotherapy may have a synergistic effects. So this can be explored in the further trial. Thank you.